Good afternoon, everyone, from Bangkok. This is Worakan. I'm sorry that I couldn't be there in person, unfortunately, because of my personal challenges. But I'm grateful to be at least online with all of you for the APCIS 2024. So my talk today is about catheter intervention of stenotic branch pulmonary arteries. So I have no disclosure on this. Just to start with the cause of pulmonary artery stenosis, as you can see that it could be congenital or acquired. So congenital is like the syndrome like Noonan or Williams syndrome, Alagille. But acquired, you can have like post-MBTT shunt or post-repair. So this session actually is about TOF, and this is one of them, TOF repair, like bilateral BT shunt. Here you can see that may pull the RPA and LPA up and causing stenosis. When to intervene? I would say that if the patient got RV hypertension or the patient has symptoms or the flow mismatch. So flow mismatch means that if you have lung perfusion less than 35% of actually affected lung, so that is indicated. And this has been published years ago, almost 12 years now, that these are still indicated in class 1B for AHA recommendation. And of course, if you have like the PR severity, which is quite torrential, or you have reduced right to left shunt, you have to reduce right to left shunt at atrial ventricular level. So these are things that you would like to maybe somehow tackle it. Or if you have obstruction in low flow stage, which is in like Promphan circuit, well, not in the top case, definitely, but this is one of the indications. Or the patient had the aneurysmal formation, the vascular rupture. So this is also the thing you need to intervene. How to intervene? Of course, you may deal with this stenosis by using balloon angioplasty or stent implantation. Or if you have like interruption, I will show you later on, you may need to get a Y or R perforation followed by balloon plus or minus stent placement. Well, the indication of balloon angioplasty, of course, if you have significant peripheral branch stenosis or you have significant distal PA branch stenosis, or you have like main PA stenosis, but somehow you may try to use this modality first in small child or small babies. These are the things that you may need to considering. Of course, I won't go through the techniques on the balloon angioplasty, but just to emphasize a bit that in particular case that you may need the cutting balloon, the case that you have resistant lesion that fail to respond to standard or high pressure balloon, and you should avoid if you have a very tortuous vessels that you need to tackle it, or you have the artery that acutely angle where the microtome can reach, or you have stenosis that joining a native vessel to artificial tube, something like MBTT shunt or Cortex tube. So those things you need to be very, very careful and likely that you should not do the balloon, cutting balloon for this kind of stenosis. So the major indication of stent implantation is actually you need to considering using this in a proximal or distal branch pulmonary artery stenosis that the vessel and patient is large enough to accommodate with stent, and also this should be capable for being dilated to adult diameter, or in the patient critically ill, that just balloon angioplasty is not enough to tackle that stenosis, or other things that this is kind of thing that kind of bridging procedure for the next surgical treatment later on. So stenting, when just to emphasize that if you have proximal stenosis and that is large enough most of the time, external compression, of course, you may need to put something inside the vessel to open it up. If you have kinking, tenting, or having the intimal flaps, or recoil, or restenosis, or vascular rupture, or early post-operative patients, those things that you need to considering for stent. In terms of the stent itself, you need to think that if you have like a very curved pulmonary artery, which is unlikely at the main branch, or you have very, very rigid area that you need a very high radial strength. And the profile, of course, if you deal with a small child, you need to be very careful on putting big sheath. But likely that it'll be okay if you go for the venous access. Strut wall architecture, of course, and you need to check whether the stent you're gonna implant gonna tail the side branch of pulmonary artery or not. Degree of shortening also the thing, because in the future, if you want to dilate it later on, you need to be very careful whether that can be even more foreshortening and not covering the area of interest or not. And last but not least, the final diameter, especially when you deal with the small child or not growing up patient. Stent design, of course, you have like closed cell and open cell. I won't go through this, but be meticulous on selection, because the closed cell likely to be have a strong radial force, but likely to get fracture if it's get to the bend, and also that we're gonna not be able to dilate at the side branch quite much. And last but not least, it's gonna foreshorten quite badly in some of the cases when you open up too much. So here is an example of a post-top repair with proximal LPA stenosis. And as you can see that with this, of course, initially you need to make sure that this is significantly reduction of the flow. And with this, we put the EV3 Max LD stent mounted with Z-mid balloon of 14 millimeter. And also just to make the proximal part of the stent near the peer bifurcation getting bigger, we also use the Coda balloon to dilate the proximal part. And here's a final result. And this is an example of the patient, quite interesting, post-top repair, but somehow got interrupted RPA. And as you can see, there's a big gap between the distal RPA and the proximal RPA here. And this is what we found after we got the primary vein wedge injection, and you can see the gap there. And with that, by using the thermal straight guide wire 018. So by meticulously pushing, spinning, and back and forth, and eventually we can get through. So with this, well, unfortunately, I cannot show you in different plane, but just to share with you that when you do this procedure, you need at least 2 planes in order to make sure that your tip of the guide wire is in the right position inside the pulmonary artery. So with this, of course, you need to have a good check angio, make sure that you are inside the vessel, and the tip of the guide wire should be freely moved. And after that, then you can advancing this straight catheter through that kind of guide wire, and then you reconfirm again with this catheter whether you are inside the pulmonary artery, and serially dilated with small balloon. In this particular case, we use Evercross 6x40, following by putting valio stent. But unfortunately, now we don't have the valio stent anymore in my country, and I think in many parts of the world. And after that, we need to also take care of the side branch to open up the side branch at the right upper pulmonary artery. And this is the final result. As you can see that with that, we can rehabilitating the pulmonary circulation on the right side very nicely. And here's another example, thanks to Supa and her team at PSU, post-top repair again. And then somehow you can see that the LPA is completely gone. And it's very difficult to see where's the distal, but it looks like there's a little track going from the proximal LPA to the distal pulmonary artery. So in this case, we are lucky enough to just put the choric guide wire, and then with that sequentially dilating with the smaller balloon, and then getting into the bigger balloon, and then stenting it. And as you can see here, that eventually we can reperfuse the left pulmonary artery. of course, this you have to be, redilating again. So I personally try not to completely open it up, from 0 to like its nominal diameter. There's no rush unless you have like a very, very difficult to get access in the future. So with that, you may need to, try to increase the size as much as possible. But in this particular case, in the next 6 or 12 months, you can come back and put a higher pressure balloon to dilate it, to make it like a bigger one. And here is another example, post-top repair with severe LP osteocyanosis. Again, you can put the EV3 max LD very nicely. I think I showed that already, but again, even the patient is quite small, 8 years old, a post-top repair, but you can use the EV3 max LD. And this stent is, intentionally to implant it in a small child like this, because we are expecting the growing of this pulmonary artery, and then in the future we can put the bigger balloon in order to open that up even larger than what we see. So with that, we intentionally crossing the strut and then put the smaller balloon, and then simultaneously inflating this very complex stent to make it more perfused to both left and right pulmonary artery, as you can see in these clips. And this is the final result. So now the flow can go to both left and right pulmonary artery without obstruction. So this is a thing that you can be using the double balloon technique in order to tackle this complex obstruction near the bifurcation. Intraoperative stent placement, of course, this is a thing that you need to discuss with the surgeon, because in a proximal lesion, and the surgeon somehow it may take a longer time, especially when we have like angling of the pulmonary artery or restenosis after redo surgery, after surgery. So this is a thing that the surgeon doesn't really like. So we need to discuss with them, of course, because that will reduce by the time a lot. And also you can put a bigger stent, and then eventually in the next few months or years, you can dilate it up to the nominal diameter that you may need, without disturbances of the vascular injury of the femoral vein, or and the patient can be able to treat it into the final destination very, very nicely. But be careful, because you may injure the distal vessel, you may tear the side branch. Of course, you need to discuss that with the surgeon, and also you need to have a good plan with the CT imagings or the previous angio that you had. And residual distal stenosis, this is a thing also you need to considering. So here's the data of feasibility and safety of unzipping the small diameter stent in the blood vessel of piglet. Very interesting paper. Thanks Chairman, his team published in 2016. Just to share with you that most of the stent can be unzipped at the twice of their nominal diameter within less than 20% foreshortening. Complication, of course, it can start with very detrimental complication up to just stent migration, balloon rupture. So those are the things that you need to be aware on the table. The best thing is you should not have this happen. So be prepared on that. Risk factor, I would like to say that if you deal with a newborn's baby, body weight is smaller than 4 kilo in emergency status, or if you have like history of prior SAE, or diffuse bilateral severe pulmonary arteriopathy, like a syndromic disease, or associated with severely decreased pulmonary blood flow and cyanosis, or associated with left side obstruction. And in emergency status, I did say that, sorry for that. But those things you need to be very careful. So here's one complication, a stent fracture. And as you can see here, that we implanted 2 stents, Genesis XD and EV3 LD Mega. And somehow, few years back, that Genesis has been fractured. So with that, we have to reinforce that area by putting another stent, which is actually EV3. So with that, we can eventually treat the patient quite well. So in conclusion, ladies and gentlemen, I would like to say that catheter intervention for stenosis pulmonary artery, you need to start with reasonable indication. Make sure that you get a good indication for this. You need to intervene with the modality instruments that match with the etiology. So you need to understand a little bit whether what is or what are the etiology of that before you tackle. Complication can occur, so be meticulous in all steps. Reintervention may require, so of course you need to follow up. So I've stopped here. And once again, thanks Zoe and all the APCIS organizing committees for allowing me to be here online with all you guys. Thank you.